So, a very warm welcome to everyone. Today, we are on our 14th session for the Ocular Genetics Interest Group. And I would like to thank everyone who stuck around and for contributing constantly to this group. We are learning a lot over the year. And to begin, we have two very interesting and experienced speakers with us. First, we will have Dr. Sirisha Senthil, who's the head of glaucoma services at LV Prasad Eye Institute in Hyderabad. And she has obliged us many a times at OGIG by giving different sessions, and we have a lot to learn from her. She will be speaking about IRD and angle closure, best and what else. And following her is Dr. Shailja Tibrewal, who's a pediatric ophthalmologist at Dr. Shroff Charity Eye Hospital in New Delhi, our OGIG mentor. And she is speaking on seeing isn't believing, and we'll keep her case a mystery to solve. So with that, over to you, Dr. Sirisha, and we can start.
Yeah. I hope you can see the slide and you can hear me as well. Okay, so this is something that we actually put together with a lot of thought. So when you see something very abnormal or there is a problem or a complication or you're seeing something new, it's okay. We see it and then we feel that maybe we've detected something new or maybe it is something different and this patient is behaving in a different way. And in the next, let's say, few months, you see another patient who's also presenting in the same way or behaving the same way or has a similar kind of a complication despite your best attempts to do a good job. And you know that there is some pattern. And then when it happens for the third time, so this time you have to hit yourself to say that there can't be a pattern which is similar so many times. So we know that there is something not okay and that we need to dig deeper into this. So this is how it started off. And what we understood is that patients with angle closure glaucoma who present with inherited retinal dystrophies need to be managed differently. Their glaucoma should not be treated the way we treat any other angle closure glaucoma. There we understand that they have a different kind of a pathogenesis, and hence we need to manage the vitreous to be able to help these patients control their glaucoma. So they are related to each other. So this is what I will be taking you through. How do you evaluate a young patient with angle closure? What is the role of multimodal imaging and genetic testing in these patients? And with all these, what have we learned and what is it that we can share with the others? So whenever you see a patient who's young, so typically when I say young, I'm talking about 40 years or less. Most glaucomas occur in the later age groups. That means they usually are beyond 50 or 60 years. In India, we see glaucomas in little younger age also. Angle closures, in fact, I see that in rural women, angle closures, we see them in their 30s also, even primary angle closures. But typically, we see these patients in their late 40s or 50s. But if you see somebody who's 20-year-old, 25-year-old, with completely closed angles, bilateral, and no other pathology, meaning like no other corneal pathology, no other abnormality in the iris, then you have to really think, is there something that we are missing? Unilateral, yes, I can understand. You can have multiple, those conditions that we have put together here, can have anything from iris to sclera. You can have a unilateral presentation, but bilateral presentation is extremely unusual. So I'll start off with this boy, a 15-year-old boy who actually came from somewhere close to Ahmedabad, born to non-consanguineous parents, but married within the same community with decrease in vision since the last 2 years. He was referred to us because he was one-eyed and asked JOAG for a glaucoma surgery. And when he came to us, he was on multiple anti-glaucoma medications, including oral Diamox. And the precious vision was no vision in one eye and 2200 in the only seeing left eye. He was imetropic. That means he was not a hyperope nor a myope. Anterior chamber depth was normal. He did have relative afferent pupillary defect and completely closed angles, no structure visible at all. And pressures were 25 and 21. This is, remember, he was on 5 topical anti-glaucoma medications and oral Diamox. He had a very advanced disc damage and he had a dull macula. In his axial length, though he was not a hyperope, his axial length was 20.9 in one eye and 20.8 in the other eye. And this is how his retina and the optic disc look like. Extremely deeply cupped, you hardly have any rim. And you have to really, I mean, there's not much of a difference between the two eyes, except for the fact that if I say he has vision in the left eye, I will call that as a near total cupping. And you can see in the macular area, there is some shine. Other than that, except for a dull macula, I really can't make out much. Maybe on the right side, you can say there are some pigmentary changes in the macular area. Now, what is the diagnosis and how do we manage this? So I will take you through the diagnosis and management at a later time point. I'll present one case which actually intrigued us to understand what was going wrong in these patients. So this was again a young patient who presented to us in 2019. He was operated elsewhere for trabeculectomy with mitomycin C, and he had flat anterior chamber in that eye. And when he came to us, his left eye pressures were extremely high. So this was the right eye flat bleb and shallow to flat AC. Right eye had, that is the operated eye, had 26 IOP, and left eye, the unoperated eye, for which they had actually referred the patient to us, had 50 millimeters of mercury pressure. This is the right eye, literally flat AC, meaning like this iridocorneal touch. And then in the pupillary area, almost the iris is stuck maybe between the lens and the cornea. You can maybe pass a hair, nothing more than that. Such shallow anterior chamber. And his pressures were slightly on the higher side, even in the right eye. And he had blood vessels going all over the iris. In fact, they were also crossing in the pupillary area. And now this is the left eye of the patient for which they had referred the patient for surgery. So when you know there is a right eye, obviously the diagnosis is malignant glaucoma. It's not difficult to diagnose that. There's nothing else posteriorly. And when you have malignant glaucoma in one eye, we know history repeats itself. The contralateral eye of the same patient, when you go and do a trap, again they will develop a malignant glaucoma. So that was the worry. And that is why we had actually investigated. If you see his axial length, he's not an ANOF. He's not a high hyperope, but axial length is almost normal. And this is his UVM that shows you the lens which is stuck to the cornea. The lens is slightly larger, whereas the left eye, very shallow anterior chamber, and the lens is of normal thickness. And this is his posterior segment. Extremely pale discs, highly cupped, and there's some dull macula. See, you have to remember that whenever somebody with such an advanced glaucoma comes to any specialist for that matter, when we say right eye vision is 2400, left eye vision is 2050, we will say that decrease in vision is because of advanced glaucoma. This is what conventionally we do. And on top of that, the patient also has high IOP, because of which we'll say, okay, advanced damage, high IOP, both will explain the decrease in vision that they have. And this is exactly what had happened to us also. We did not really worry about the dull macula there, and we did not really investigate. So this is his visual fields, very, very advanced damage with small island of vision. And if you see, there's also some central scotoma that is there. This also can happen in very advanced glaucoma. So we again did not pay much attention to it. So right eye has a phakic malignant glaucoma, left eye has uncontrolled glaucoma. Now we need to treat it. So what do we need to do? So because there is a risk of malignant glaucoma, we thought, let's go ahead and do a trabeculectomy. Maybe we can add an IZHV, that is iridozonulohyaloidovitrectomy, along with TRAP, and we should be able to manage that malignant glaucoma. So I went ahead and did the surgery. Surgery was uneventful. We did all precautions, pre-op mannitol, make sure there was a good massage that was given, an eyeball was on the softer side. Went ahead, uneventful trabeculectomy, and then along with it also went ahead. You can see that inferiorly, maybe I can just take the video here. So I just want to show you that IZHV inferiorly. This is a phakic eye, mind you. I'm using a low cut rate of 500 cuts and going beyond the equator of the lens, going through the zonules and into the anterior vitreous, we will be able to actually clear up that anterior hyaloid, and then went ahead and finished the trabeculectomy, and surgery was completed. So there was no problem as such with the surgery. And then you can see well-formed anterior chamber. Okay. And there was no issues. There was no issues as such. This is day 1 was good. 1 week was good. I'm showing you for want of time. I'm showing you 15 days. He had further shallowing that happened. And now he has recurrence of malignant glaucoma in that eye. When I say recurrence, possibly developed a malignant glaucoma here despite the IZHV, and here because the iris was stuck to the cornea, I think that area was completely closed. Now what do you do next? We went ahead and did a core vitrectomy and tried to deepen the anterior chamber. So once the core vitrectomy was done, this patient was okay. Pressures were even otherwise well controlled. Anterior chamber had deepened. You see the previous opening had closed because of the shallow anterior chamber, and patient developed peripheral anterior synechia in that area. Adjacent area, another IZHV opening was made and the lens was clear. There was no problem. And we don't have to sacrifice the lens always. I'll tell you why. Okay, and this patient later, when we assessed, when we asked for further evaluation, multiple things that were done, fundus fluorescein angiography was done, macular OCT was done, and then we had the EOG, ERG, and genetic testing. And genetic testing revealed BEST1 and an autosomal recessive inheritance for this patient. So I'll just take you through briefly what are these, because when we started, even when somebody said inherited retinal dystrophies, even that I was not aware of what all comes under these inherited retinal dystrophies. But at least of the many that we have, the three common conditions that can be associated with angle closure in the young and who have a very, very high risk of developing a malignant glaucoma, not just with trabeculectomy, even following a cataract extraction. The reason why I'm telling you this is because often when we discuss this, people say you have a very large lens or an anteriorly placed lens, go and do a cataract extraction and the problem will be taken care of. It's not so. Even following it, in fact, I have another set of patients for whom they were referred for a shallow anterior chamber and progressive myopic shift following a cataract surgery. And what was missing was that they did not diagnose the inherited retinal dystrophy like it can happen for most of us, especially if the vision is good, and they do develop malignant glaucoma even after an uneventful cataract extraction with in the bag intraocular lens. So it's not just the trabeculectomy alone, but any intraocular procedure that they undergo, they can develop the serious complication of malignant glaucoma. If you don't treat it, their intraocular pressure goes up, uncontrolled. You can lose the eye because of uncontrolled glaucoma, or because of lenticular corneal touch, iridocorneal touch, they develop a corneal decompensation, vascularization of the iris. After that, that's the beginning of the end. You can't even do a keratoplasty, because even if you do a keratoplasty, because of the iris that is stuck to the peripheral part of the cornea, it will be extremely high risk and the chances of rejection are going to be very, very high. And it's going to be a downhill course. So at any cost, we have to prevent malignant glaucoma. So the three inherited retinal dystrophies that we came across that has associated malignant glaucoma are best vitelliform macular dystrophy. Often it is autosomal recessive, but sometimes even autosomal dominant, X-linked retinoschisis, and retinitis pigmentosa of various variants. So their angle closures are refractory. Even after you do a laser peripheral iridotomy, their angles continue to close and they develop a zipped angle closure. They often need surgery. And whenever you go and do whichever surgery it is, whether it is combined surgery, whether it is only cataract surgery or a TRAB, they invariably develop a post-surgical malignant glaucoma. So this is a slide that actually Deepika had put together. What is it? So for me, this was a new learning. For me, anybody with these schitic kind of lesions, according to me, it is retinoschisis. This is what I had first diagnosed it as. And when I showed it to the retina colleagues, they said it not necessarily. You can have this kind of schitic changes in multiple diseases, and Best retinopathy is one among them. So you have a macular OCT that revealed retinal schitic layers with cystic fluids filled cystic spaces, thickened photoreceptors in the parafoveal area, or loss of photoreceptors subfoveally. They have very peculiar serous subretinal fluid with the clump-like pigments, not pigments, clump-like deposits that you see in the subretinal area. So when we looked at the retinal dystrophy, so if you ask me, does everybody with a Best retinopathy or a X-linked retinoschisis or an RP, do they have an angle closure and are they at risk of developing a glaucoma? No. When you look at completely all those patients with retinal dystrophies and primary angle closure, when we looked at that, in fact, Deepika had worked on this paper also, the prevalence of angle closure glaucoma in these diseases is not very high. They range from 0.19 to 2.13, which is the prevalence that you see in any angle closure in any general population. Only thing we need to understand is that they develop angle closure at a very, very young age. And among those people who develop angle closure, they have a relentless course. So that's what we need to remember. Is the prevalence high? No. But among those who develop it, they have a serious disease. And malignant glaucoma in these eyes is something that we need to worry about. So the first case that we published, that if you have a condition like this, where so let's say you have somebody with a Best retinopathy and you know that this patient requires management of glaucoma or uncontrolled glaucoma, what is it that we need to do? So we need to do a trab. We can do trab with IZHV, or we can do a trab with core vitrectomy with IZHV, or we can do something that we have done in this patient, where you don't even have to do trabeculectomy. Just go ahead and do a pars plana vitrectomy with an IZHV, or if the patient has a cataract, just remove the cataract, meaning lens extraction with an IOL implantation, PPV with an IZHV. That alone can take care of the glaucoma. So this was first of such cases where we completely moved away from doing any glaucoma intervention and taking care of something else that was actually causing the problem. And this was the paper that we had published, and Deepika had worked very hard on this, where we said that if you have a condition like this, we definitely need to do electrophysiological tests and genetic testing to understand what the underlying condition is. Of course, deep phenotyping and understanding what the clinical picture is very, very important. But with regards to glaucoma, these patients progress relentlessly, no trab or tube without managing the vitreous, and vitreous management is very critical in these patients. So now going back to our patient, with the understanding that we had with our previous experience, what did we do? ERG and EOG was done for this patient, which showed a severe reduction in the light peak to dark trough ratio, Ardens ratio, indicating a severe generalized RPE dysfunction. And full field ERG also showed decrease in the dark adaptation times and absence or reduced amplitude of B wave and delayed implicit time. Genetic counseling and testing was done. This boy's elder sister also had similar kind of problem. And that girl was diagnosed to have bilateral ICE syndrome, and she underwent a glaucoma surgery. She had flat anterior chamber and corneal decompensation. She had removal of the lens and a corneal replacement, and she is also one-eyed. All this was done in another institute. And she was, in fact, when we saw her report, she was diagnosed to have ICE syndrome. That is because obviously the iris was stuck to the cornea, that after the intervention, because of the shallow anterior chamber, and malignant glaucoma was not diagnosed. And this boy was found to have a BEST1 gene as well, heterozygous. And he also incidentally had RPE 65 gene that came as heterozygous and autosomal dominant. I don't know what is the significance of this in this patient. Maybe Deepika and some of you can tell us. But this patient, with our previous understanding, underwent a PPV with an IZHV primarily without doing a trabeculectomy. This is one-eyed, mind you. It needs a lot of thought process and a guts for you to actually not do a trabeculectomy, but convince your vitreoretinal surgeon to do a core vitrectomy and an IZHV in a phakic eye. So this boy, after that, the anterior chamber deepened, vision stabilized, and pressures were controlled on medications. So what exactly happens in these patients, we really don't know, but what we hypothesize is that they have something called as a vitreoretinopathy. They have very thick anterior hyaloid, possibly doesn't allow the fluid to move, diffuse from posterior segment to the anterior segment, and that possibly causes progressive push of the lens iris diaphragm and shallow anterior chamber, causing angle closure, and the same reason why somebody can also develop a malignant glaucoma. So what they do not respond to the conventional treatment, and so what they actually need is a proper diagnosis, doing all the necessary investigations to be able to diagnose the condition. And once you know that they have this condition, we need to treat them in a different way. So this is a patient who underwent a pars plana vitrectomy with an IZHV and trabeculectomy with mitomycin C, did not develop a malignant glaucoma. This was a patient who underwent a core vitrectomy, lens aspiration, IOL implantation, and an IZHV, did not develop a malignant glaucoma. And same way, we moved ahead and we said we won't even sacrifice the lens, did only a core vitrectomy and an IZHV, and did not develop malignant glaucoma. I'm saying did not develop malignant glaucoma with the time of follow-up that they have had. Some of them have had a follow-up of close to about 5 to 6 years also. So these are all the people who have helped us. So just to conclude, to keep here on the slide, to conclude, inherited retinal dystrophies, when they present, any of these patients present with angle closure or angle closure in the young, when they present to the glaucoma clinic, and when you know that this is not something that is conventional, please go back and evaluate these patients. Sometimes you just don't see anything else except a subtle, maybe RPE changes in the macular area or a dull reflex, that's all. So they require evaluation, including imaging and electrophysiology, to be able to diagnose the condition, and a genetic testing will definitely add to it. And only when you understand what is happening, I think appropriate management will help these patients prevent a serious complication. Already we know retinal dystrophy we can't change, but at least malignant glaucoma and glaucoma is something that we can definitely prevent and prevent them from going blind. Thank you.
Thank you, Dr. Sirisha. Wonderful case series. And Deepika, congratulations for the good work. It's really very interesting to know. I mean, at least I was not aware that these patients are at risk for malignant glaucoma. And it's a good learning for me and everyone, I think so. One thing which I was thinking that, because of glaucoma, we always get this RNFL OCT done. And along with that, there is a GCC which comes with the macular scan. So, presence of a retinal dystrophy, all of these which you have listed will have some macular changes, which will be not just localized to the ganglion cell complex on the scan, but to the, the ISOS junction or the outer retina as well. So, paying heed and looking at that could probably kind of explain why the vision is so less. Although, yes, advanced glaucoma can cause it, but that can sometimes, clinch a diagnosis that this could be something having some retinal problem also.
Yeah, no, I agree with you. That is, if we really think about it, we will see. Otherwise, don't even bother. And such an advanced glaucoma, we don't do an OCT because everything is going
Correct.
red.
Yeah.
Who really bothers? Yeah, so that's one thing. And then just to reiterate the point, and how often do you see malignant glaucoma in them? 100% of the time. There's nothing 100% as far as medicine is concerned, I know that. But that is that common in these patients. Whether they'll develop immediately or will they develop after 1 month or develop at a little later time point is a different question.
So, Sirisha, I have a question here. Like you said that you have to remove the lens and maybe IZHV, or maybe sometimes you don't have to remove the lens, just the vitrectomy, and vitrectomy and iridotomy will help. So, like in non-ophthalmos, basically the treatment remains same. Although here the patient are not hypermetropic, and they don't have large lenses, but because of the vitreoretinopathy, where the anterior hyaloid is thick, there are more chances of having malignant glaucoma. So it is better. So you won't do trabeculectomy in them, and you will just do the IZHV and or maybe vitrectomy and sacrificing the lens. Like, what is the protocol in such type of patients? If there is intractable glaucoma, so there's intractable glaucoma, the IOP is not controlled. So what will you do?
Yeah, sure. So I think it's a very important question. Non-ophthalmos spectrum as well as the spectrum of IRDs with angle closure are completely different. So in patients with, it's not like patients with non-ophthalmos don't develop a similar kind of a complication. Sometimes eyes with non-ophthalmos also may have an inherited retinal dystrophy because they also have a predisposition to that. But just the non-ophthalmos, if you ask me, with no other pathology, the treatment, even if the pressures are elevated, to me, the treatment is removal of the lens. And there we do a posterior sclerotomy because there the problem is you're worried about uveal effusion and things like that. So you do a posterior sclerotomy, partial thickness opening and a deeper or a full thickness sclerotomy so that you drain the fluid and want to prevent intraoperative and postoperative uveal effusion. So that's the major problem there. Malignant glaucoma can happen in any angle closure eye, small eye, especially somebody is on very long time pilocarpine and things like that. But you don't develop. So in fact, if I have operated about, let's say, 50 nanophthalmos patients in the past year, malignant glaucoma would have happened in 1 or 2. So in fact, we've put together our series now, but it's not very common. It can happen, they're predisposed, but it's not very common. Same way, even in angle closures. Any primary angle closure glaucoma that we operate can develop malignant glaucoma, but that is extremely rare. So they do happen, they are predisposed, but that's not very common. So I think nanophthalmos is a different spectrum altogether. There I wouldn't be that much worried about malignant glaucoma. I would be worried about doing any surgery in that eye because intraoperative complications are high. So as long as I prevent that, post-operatively, I'm not that worried.
No. Here you said that malignant glaucoma is common. So you will not, my question is just if glaucoma is intractable in such eyes, will you go for trabeculectomy or you will remove, you will do IZHV and as you suggested because anti-hyaloid is thick and all in these eyes?
In IRDs, inherited retinal dystrophies.
Yes.
Yeah. So the thing is, to me, it is like this. If they have even an early cataract, if somebody is in their 30s, even if they have an early cataract, generally these people develop cataract a little earlier, right? I will remove the lens, put an IOL, and of course, core vitrectomy with an IZHV. If they have clear lens, don't sacrifice it. The reason why I say this is because if they have clear lens with whatever little bit of accommodation they have, near vision is not so great because of the IRD that they have, but near vision is usually N10 to N12. They can manage. The minute you go and remove that crystalline lens and make them pseudophakic, near vision is N36, N60 or even worse. So you lose that. In fact, the quality of vision goes down so significantly for them. So that's why I said, like, if they don't have a cataract, don't sacrifice the lens. Lens is not causing the problem. The problem is with the vitreoretinopathy. And that is the reason why we are able to even manage those phakic eyes. And it's not like because it's a phakic eye and you're going and doing an IZHV, will they develop a zonular dialysis? Will they develop, phacodonosis and things like that? Nothing will happen. Among the 360-degree zonules, you're going and removing one Glaucoma, nothing will happen. Lens will be stable. So if they have a clear...
And no trabeculectomy.
No trabeculectomy.
Okay. Even if the pressures are very high, and that was my question. If the pressure is 40 to 40 and not controlled on medical management, still you will not do trab, but you will do IZHV.
Yes. In some situations, like I said, we evolved from there, from not doing anything to doing combined to can you move on to even sparing the lens.
Okay.
Suppose you do this and then post-operatively, because the angles have been closed for a very long time, the pressures are not going to come control. In an eye with a deep anterior chamber, you can always do a glaucoma surgery at a later time point.
Okay. Very nice series.
Deepika, would you like to add?
Yes, sure, ma'am. Yes, thank you for very nicely putting down, ma'am, everything. I would like to add that in the IRDs, like ma'am showed in the last image, there was one eye, OCT image, where in the right eye, it was a foveal thinning, and the other eye, there was chysis. So I'd like to add that, so these IRDs are evolving, and we will see the patients at various stages. So the macular changes and the OCT changes, the autofluorescence changes will be evolving. So we might not have typical retinal characteristics all the time. So that's why, like Sirisha ma'am said, so the key is angle closure in young patients with some retinal pathology you are seeing in the macula. So if we see that, we need to evaluate completely. And sometimes they will be in the burnt out stage of IRD, like all IRDs will go to atrophy towards the end, like all the retinal layers will become thin, and sometimes everything looks the same. So that's when EOG in the best spectrum and genetics will play the key role. This is what I would like to add, because when we were seeing the cases, every OCT was slightly different, not everything was the same, and that was also challenging, whether it is retinoschisis, which has become a atrophy, or the best spectrum, which has become atrophy, was challenging. And in one of the slides, ma'am showed X-linked retinoschisis. Though we feel that 99% of the patients of X-linked retinoschisis will have foviomacular schisis, but as they evolve, they will develop into atrophy. So, but still, when we do the ERG, they will still show the pattern of electronegative ERG. So, this is when electrophysiology and genetics combined will help us. That's it. Yeah. Thank you.
Can I ask a quick question, Sirisha and Deepika?
Yes, Manju. Go ahead.
So yeah, I just wanted to ask, so would you like you know, consider doing a gonioscopic examination only when you feel that the pressure is raised, or you try to do it on every, because some of them may be pretty young and you may not be able to do it on everybody. So just for looking at the angles, how else, like other than slit lamp or checking the pressures, what else would you, or would you subject them to a EUA as well?
Oh, very young children, generally they don't. If I say the youngest I have seen, that's why I presented that case. Youngest I've seen is 15-year-old.
Okay, okay.
And
So,
when it present at that age, it
so
is
in the second decade, so they'll be reasonably
in the
cooperative.
second decade.
Okay, okay. Thanks.
They will be old enough and cooperative enough for us to do the testing.
That is also one of the proof that IRD has begun very early in life, and then angle closure is coming later. It is a kind of secondary angle closure due to IRD pathology or not. I think that is the question here.
Right, right. Yeah. Thank you. Thanks, Deepika.
Thank you. Dr. Shailaja, I would like to add one more point, because you told about the OCT, which we do during the glaucoma, like the GCL1. So I believe most of the OCTs which I have seen, the glaucoma OCTs are the time domain, where we see the colored images. But for these changes, the subtle changes, when especially they're in the atrophy or some other changes, better to do a spectral domain, the black and white Heidelberg machines. So they will really help with autofluorescence. Sometimes it is very difficult to pick up the subtle retinal changes in the time domain, and we might miss, like ma'am said. If we are not looking, we will miss it.
So I don't know how this is just true serendipity that my case is also very similar to on these lines, you know, and the same things will kind of come up in the case. So Deepika, just hang on and I'll need your inputs in that case also.
Sure, sure. Thank you.
So should I start, Riya?
Yes, thank you, Sirisha, ma'am. Yes, you could take it away, Dr. Pai.
Yeah, is my screen visible?
Yes.
Yeah. So this case is actually again a learning point for me because something not I would not see very often. But being in a genetic clinic now, I'm getting to see all these weird retina cases as well. And so this 9-year-old male child was referred for a history of decreasing vision, which was slowly progressively decreasing since the past 2 years. He was using glasses since 1.5 years, and the referral actually showed some disc pallor, temporal pallor, and that's why I was referred for a neurophthal evaluation. Then from the neuro clinic, it referred for a genetic evaluation because there was some family history as well. So when we examined him, he had 6/18 parts vision in both the eyes. This was his best corrected. And as you can see, he had a simple myopic astigmatism in both the eyes. The color vision was affected. He was reading just 2 plates out of the 17 Ishihara plates, and the contrast was also greatly affected. This were the fundus photographs, kind of unremarkable. If you want to look at it, there was some trace temporal pallor. but otherwise it was all normal kind of a looking. And with this kind of, shiny looking macula, and I was thinking probably this child is either malingering or what is happening, or maybe it's a subtle pallor which we are missing. So the first go-to thing was probably malingering, or some mild form of an optic neuropathy happening here. We That's why the history taking was more in terms of, picking up some subtle optic neuropathy, like any vitamin deficiencies during a serious illness or hospitalization in the past, any long-term drug therapy like taking ATT. Birth and developmental history was normal to pick up some kind of a birth asphyxia or something. There was no systemic complaints. He was otherwise good in academics, and there was also no photophobia or nectalopia. So at this point, I was thinking what it is, but there was a family history of similar problems. So we explored that, and his father was also having a history of vision loss since childhood, around 12 years of age. This is 21 written wrong here, but it was around 12 years of age. He had this, and it was again very slowly progressive. He had this vision loss, and according to him, his mother was also affected with something like this, but not aware of what was the age of the onset. Apart from that, the family had some history of, the mother had hypothyroidism, rest were okay, but they also had this multiple abortions with this couple, and currently the mother was around 4 months pregnant when they came to us. So at this point, I was thinking, oh, maybe this is still, it's something hereditary definitely, but is it a hereditary optic neuropathy thing, or it is a very early macular dystrophy which we are not visible here, and thinking in terms of occult macular dystrophy here. So went ahead with the optic neuropathy hypothesis, and did a neuro package that we do as visual field and OCT here. So in the visual field, there was a central scotoma. Again, could not differentiate between the early macular or the optic neuropathy, which both can show a central scotoma. Looking at the RNFL OCT here, we can see that the average RNFL thickness was slightly below, but still under that normal range. I would expect it to be around 100, but it was around 86 something. Everything is green here. If you look at the ganglion cell analysis, this is what I was talking about, is that yes, there is some amount of GCC loss which is seen here. Now, if I'm seeing a GCC loss, now I'm with a normal RNFL, I'm thinking maybe again it's a very early optic neuropathy, or is it something a secondary kind of a GCC loss due to some retinal problem? And as Deepika was also pointing out, in this time domain OCT, I couldn't really make out if there is any subtle ocular macular problem here. So went ahead with an autofluorescence here. This is the near infrared autofluorescence. Very small speck of hypoautofluorescence in the center. Now, in the near infrared, you should see a hyper autofluorescence at the fovea, and there is a hyperautofluorescence, but the center has to be the most hypofluorescence, and this is very, very center, small dot of hypoautofluorescence. I thought maybe it's normal also, I'm imagining, but this is the spectral domain OCT that we ordered. Then here probably there was some defect in the interdigitation zone. That is the only place where I felt this is like kind of discontinuous. The rest was still okay, but if you compare it with this normal OCT which has been shown here, I felt that it could be normal also at this point. So now again I was thinking, oh, this none of my examination is clearly concluded whether I'm dealing with an optic neuropathy here, or I'm dealing with a early or an occult macular dystrophy. I'll come to the slides where we describe how an occult macular dystrophy looks like, but I was thinking maybe it's a very early stage because this is a child here. So then what next to do? So I was thinking maybe further testing like a multifocal ERG or a pattern ERG may differentiate, or directly jump to genetic testing. But then what we forget most of the time is that we have a very important tool with us when we are examining hereditary disorders, that you have the chance to examine the affected family members and can know what is going on in the family. Is it the same problem? Maybe the father has a little advanced version of what the child has and has a full-blown disease, which will help me in diagnosing the child better. So coming to the father now, the father was a 36-year-old at the time when we examined. His blurring of vision was since 12 years of age, as I mentioned, very slowly progressive. Right now he's 636. His contrast is again 40%, color vision only demo plate. very very mild simple myopic astigmatism there. Near vision is N18. So this is again a very typical central problem, which is either, but now if you look at his fundus, his macula is not so shiny as a child. You can see that there is a zone of this yellowish kind of a zone or orangish zone around this, which should have been all reddish here, and a dull zone surrounding it. The temporal pallor is slightly more in the father, and apart from that, of course, there is a little bit more cupping also. And the autofluorescence here, you can see again, this is like a more advanced version of the child, where we were thinking there is a central hypoautofluorescence which is more marked here, and the surrounding hyperautofluorescence in the autofluorescence. And this is what was seen on the spectral domain OCT here. Definitely there is an absence of, now this is something which cannot be missed. There is absence of the interdigitation zone, even the ISOS junction, and there's some thickening of these layers here, and there is a fluid or a clear fluid probably, subretinal fluid here. The inner layers are quite okay. So now when I started with an ocular macular dystrophy, actually I was thinking the father would probably have just these absent layers, and there will be macular thinning. That is what is seen in occult macular dystrophy. I was not expecting this raised kind of a thing, and I was really not knowing what it is at this point. This is again the RNFL layer here, RNFL testing. Here you can see that the average RNFL is much more thinner as compared to the child, and this OCT is also showing these changes and GCC thinning. As expected, the visual field was showing central scotoma. So what do we have now? So this is a familial disease. There is definitely a foveal involvement, more in the father, probably very early in the child. Optic nerve involvement is also there. There is definitely a pallor. This could be secondary to the macular involvement or the foveopathy, or is it optic neuropathy in the first place? Could there be? There is no systemic history. It is slowly progressing. Child probably has an occult disease or an early disease, but the father not so occult disease. So when I started with an occult macular dystrophy, that dropped down lower in my differential diagnosis. What also intrigued me, because recently I had seen one more case where there was an evidence of foveopathy and optic neuropathy. So I was thinking maybe this is the same thing. So I went back and checked, that specific mutation as well. So this was a case where there was an SSBP1 related optic atrophy, where I had diagnosed it as actually probably a retinal dystrophy, and turned out to come as a SSBP1 related optic atrophy. So what is SSBP1 related optic atrophy? This is little diverging from the current case, but it will just show the thought process why I'm thinking foveopathy and optic neuropathy. Is that in this particular gene, is the only gene in which you could have a foveopathy in a primarily an optic neuropathy. So here the patients will have absence of a bilateral tiny defect of the ellipsoid zone or the interdigitation zone in a patient actual there is an optic neuropathy, and this gene actually affects the mitochondrial ultimately affects the mitochondrial gene. So here you can see again very typical, very similar to what we had seen in the child. So there is a temporal pallor, fovea totally looking normal, and when you do a SD-OCT, then you can see this defect here. Okay, so this is so small defect, it is showing that in one scan it is coming, other scan you can miss. So if you're not going through that scan, you may miss this foveopathy. And it was seen in around 12 patients of a 27 patient family who was affected by this SSBP gene. And as mentioned here, that this foveopathy was never described in any other genetic optic neuropathy. And this foveopathy, it does not progress. Most of the family members, even the adult ones, had the similar kind of ISOS defect there. So now coming to all this with this background in mind, my first was probably some kind of macular dystrophy, or again hereditary or optic atrophy, maybe a variant of this SSBP only. And occult macular dystrophy, which I started with, fell down to the third, which could still be maybe the father had a advanced version of ocular macular dystrophy, which I am not probably aware of. So we went ahead with genetic testing to conclude for the family, and because we gave all these diagnosis to the lab people, they said it is an ocular macular dystrophy and affecting the RP caused due to the RP1L1 gene. And this is a very typical mutation, the most common one with the P-arginine 45 tryptophan replacement, which is there. And it was a likely pathogenic. We confirmed it with a Sanger in the sun also. Now, does this solve the puzzle? Because I was still thinking that it is not fitting into ocular macular dystrophy, because my thinking for ocular macular dystrophy is that the fovea should be normal, the fundus should be normal, this is normal. Why are there so many changes in the father? So as Deepika was also mentioning, dystrophies, they evolve with time. So I dig deeper into ocular macular dystrophy. Now this is the classical ocular macular dystrophy, which is an inherited retinal degeneration characterized by progressive decline in central vision, but with normal fundus and normal FFA. It was first described in 1989. It's majorly described from East Asia, and there's possible under-recognition because fundus appears normal. Epidemiology, the exact percentages and all remain unknown. And it is also characterized by incomplete penetrance. That means patients may be harboring the mutation but not manifesting the disease. In the same family, you may have patients who are harboring the disease, not manifesting the disease, or sometimes they also have some variations in the degree to which they are affected. Now, this is a very typical example of multimodal imaging in a patient. So, of occult macular dystrophy, fundus again appearing normal, FFA would be normal, but autofluorescence can pick up things. And if you see this autofluorescence, you would kind of correlate it with the patient that we had, the father, where you can see that again there is a ring of hyperautofluorescence and there's a hypoautofluorescence in the center, which is there and which corresponds to this defect in the ISOS junction and the interdigitation zone. But here you can see that there is no clear space there. There is no subretinal fluid there, which is described in occult macular dystrophy. So after looking at this, I was again thinking, oh, again, is the father some other phenotype, which I was thinking? And look at this, this is the father's picture. So the autofluorescence is kind of matching, but this fluid is not matching here. So occult macular dystrophy, most of them are caused by the RP1L1, and some of them have some other genes also, but the RP1L1 is the most common. So then I thought, is this RP1L1 causing always occult macular dystrophy, or there could be something else also that it can cause? So digging deeper again into the RP1L1 gene itself, then I found that RP1L1, sorry, maybe I'll go to this one. So it causes three kind of phenotypes. One is the occult macular dystrophy. It has also been known to cause retinitis pigmentosa in some patients, and there are some group of diseases where it is grouped under RP1L1 maculopathies, where it will not remain so occult and have different kind of involvement, but essentially macula is involved because the gene functions there only mostly. So the RP1L1 maculopathies, in that even Stargardt disease have been described, and there's something called a pseudo adult onset vitelliform dystrophy. Now, when I was digging deeper, then I found that there was just 4 case reports of this kind of presentation, where there is a RP1L1 pseudo adult vitelliform dystrophy, which is probably the kind of phenotype that our father of the child has. Apart from that, as I mentioned, I was still thinking that is this father's version, a progressed version of an ocular macular dystrophy? And yes, ocular macular dystrophy, when it progresses, when you see adults with ocular macular dystrophy, or senile people with, or old people with macular dystrophy, you may see some changes in the macula in the form of some stippling there, and not normal looking macula. So then, but most of them, again, the reports are showing that there is thinning of the fovea along with it, and not this kind of a subretinal fluid and thickening as seen in our patient. So this is what I was talking about. The adult pseudovitelliform dystrophy was described in one family of mother and daughter, both having the same phenotype. Then there was this case report within a case of RP1, occult macular dystrophy paper, where they mentioned that there was this son with this kind of a occult macular dystrophy, diagnosed with occult macular dystrophy, but OCT is showing exactly the similar picture of our patient. And the father of this son was actually having the typical occult macular dystrophy kind of a picture where there was only ISOS defect and no fluid in this. So this was then described as, you know, having, and compared to the true best or the adult macular VMD, the Arden ratio would be normal in such patients. And all these 4 cases which have been described in literature, the variation in the RP1L1 gene is not the common one which is associated with the occult macular dystrophy, which is the P45 glutamate, which is there. So they had some different mutations here. Unlike our patient, which has this typical P-arginine 45, sorry, tryptophan mutation. So what I learned eventually is that pseudo-vitelliform macular dystrophy is an expanded phenotype of the RP1 gene variation, RP1L1 gene variations. Whether it denotes a progress stage of the disease or a distinct phenotype is unclear, because we have just 2-3 families which are showing this kind of a picture. In one, the son was affected with this pseudo-vitelliform macular dystrophy, and the father had occult macular dystrophy. And the other, both the mother and daughter were having the same kind of VMD. So all these 4 cases reported in literature have genetic variation which are different from the common variant. But our patient here was having, you know, the most common type which is associated with OMD. So whether the son will progress to, you know, will remain like an OMD or will progress to this VMD, I'm not clear as of now. It is very difficult to do a post-test counseling in such patients, what to really explain them, what should they expect, and what kind of a, you know, progression that they will have. Ultimately, with this RP1L1 maculopathies, you could have the ultimate presentation in a patient may depend upon the mutation load, the phenomenon of incomplete penetrance, and also the progression that happens with age. So phenotypic variations within a family, most of the time, you know, they help us answer questions, but sometimes they can complicate our thought process, like in this patient, where I was expecting an occult kind of a macular dystrophy in the father, but turned out to be something different, which kind of again made me think a lot. Then you may have to go back and to the genotype, go back to the phenotype, and vice versa, ultimately to you know, derive a conclusion from the genetic test that you have and correlate it with the phenotype. And always support from published literature is essential. If you go dig deeper and into all these papers, every one case which maybe, you know, you have to actually search for that, either sometimes match the mutation, sometimes match the phenotype, and see what is different in that case to get a clear understanding of what we are dealing with. So thank you so much. And those who are attending and would love to learn more about pediatric ophthalmology and strabismus neuroophthalmology interesting cases, you can join us for the POSN edition 7th on 20th and 21st September at the India International Center, New Delhi. We have we'll have lots and lots of interesting cases discussion in that meeting as well. Thank you so much.
Thank you, Dr. Helja. That was a great case and the first that we've seen of the kind with these findings. Any questions?
First for me as well.
Yeah.
Very interesting case, Sailja. So why do you think they have this submacular fluid-like cavity? What is there in that area?
It is not, I could not find that actually. In the best dystrophies, you know, there's this hyper, the material which is there is usually that, you know, that yellowish material, which is what you call it slow. It should be hyper autofluorescent, and it should be hyper this. But here in the best also there are stages. So when it disintegrates, that material can disintegrate and just leave that space. So that kind of thing is there. But this is a pseudo, it appears like vitelliform, but we really don't know what is there. So in one of the papers, it was said that probably it is an extension of the disease. Maybe with age it happens like that, where the two mother and daughter both had. But in the other paper where this father had an occult at even 60 years of age, and this son of 30 years had this vitelliform, so there was no explanation of what happens. The gene per se helps in the cilia, the attachment of the cilia, working of the cilia. So the axoneme within the cones and the rods, so it goes and attaches there, and you know, helps in that functioning of that particular cilium. So it is very specific to attacking the fovea there. If it is defective, then the fovea thing is happening. The interdigitation between the RP cells and the cones there get affected, which is there. Why it is so much heterogeneous within the maculopathies, it's not very clear. One case of even Stargardt's kind of a picture with RP1L1 has been described. Even occult macular dystrophy is not always RP1L1. Even CRX mutations, some of them have even these kind of mutations have also been seen. So it's not exclusive. So occult macular dystrophy could be like a clinical umbrella term where the fundus is normal, but with ancillary testing, you find some maculopathy. But interesting was that, I was actually hoping if other ka bhi occult type niklega and spot diagnosis ho jayega, kam khatam. But then you see, oh, this looks like something different. Why is there SRF there? What is it? Doesn't clinically look like a best dystrophy. So, but genetic testing, and then after genetic testing also, then it came occult. And I was saying, oh, is it really occult? But then I thought, no, that's why I thought I'll present this case, because I read also a lot because of this.
Yeah. No, I was just asking Deepika because from what little I learned, that subretinal fluid, I used to be worried. Like it looked like I know of some of my patients, their family members. There's one family who many of the family members have the similar kind of condition. A couple of them are taking intravitreal injections because they're subretinal fluid, so they're going and injecting, not knowing what it is.
Yeah. That is.
I have no idea. And then when I had discussed this with Deepika, and the few of the patients when they came, then she told me that they are the liquefied photoreceptors because of which their vision doesn't come down in the beginning, and what you see there is as fluid is not actually the fluid.
Yes.
What is
So
there in that? Maybe Deepika can help us understand.
Yeah. So when that best deposited disintegrates, then it leaves that space there. That happens usually in best, but I don't know what happened in this patient. Yeah. Deepika?
Yeah. Yes, Dr. Shailaja, very nice case. Actually, you have thought very nicely the flow, no? It was very nice. I think we would have also done the same thing. Regarding the cavity, I'll just say first about the cavity. In the best spectrum, like ma'am mentioned, it was initially we will have that elevated neurosensory area, and along with that, we'll have deposits. That is when we will not have any vision loss because it is still the interphotoreceptor matrix is still there, so the vision is still normal.
Yeah.
When they start disintegrating, there is neurodegeneration of the retina which happens. So that's when there is photoreceptor loss and RPE loss. That time the patients will have vision drop. And in the later stages, which ma'am mentioned, one of the family where we saw a small cavity with foveal thinning. So that happens in best spectrum. Thought process for all these cavities, like one you mentioned in the RP1L1 also. There are two thought process. Some of them say that it is an empty cavity. There's nothing, and probably there is just a neurodegeneration sign which is happening. The other is that RP is not functioning to remove enough fluid. So I don't know why it is there. I don't think so there is anything conclusive, at least I have not read so far. And this kind of subfoveal cavitation, it is called as subfoveal cavitation, the fluid which you showed, and it is reported in RP1L1. But it was interesting to see that the common mutation, like you mentioned, which causes OMD, is causing this. That is very new learning for me as well. Yeah.
Yep.
The OCTs in the beginning, the SD OCTs, they were abnormal. So from the OCT only, it picked up as that it is maculopathy rather than the dominant one. If you see the first OCT when compared to the normal one which you had put on the top,
the child's OCT.
Loss of the thickness of the ellipsoid zone.
Yes.
Sometimes it will be confusing, but if we trace to the temporal aspects of the scans, so the far periphery one in that macular scan had a thicker EZ zone when compared to the central one. So that is,
I'll show it for
that way we can pick it up
everybody.
early. Yeah.
Yeah. So I would admit that, I really thought that the child's OCT was okay only, because these are subtle things which, and my more training is for neuro-ophthalmology, and we think, oh, that's so little bit. But when I was reading, trying to decipher what is happening, then I realized, yes, if you go back to the child scan also, it is not really that normal. So
Yeah.
this, what you're saying is this, right?
Yeah.
This,
Yeah. If you
this,
see the
yeah,
nasal
this is,
and far
yeah.
temporal and just trace those layer. So
Hmm.
the very nasal and the temporal scans are more thicker when compared to the central one. And there is
Okay, okay.
fuzziness in the center, where we are not able to see
Yes.
a differentiation between ELM, the ellipsoid zone, and ellipsoid zones. Basically, RP anyways we can see. So that
Yeah.
is one. And this hyper autofluorescence which you showed, that is also peculiar of IRD. Yeah.
Yes,
Yeah.
yes.
Thank you. Thank you. If any other retina person has
Hmm.
joined, because the subfoveal cavitation, even I don't know what it is. If anyone would like to add anything on that, it will be helpful.
Yeah, and any other comment or questions from anybody?
Is this pathology of the photoreceptors or RPE?
This is photoreceptors.
Should be photoreceptors, ma'am, like Dr.
Yeah.
Shailaja said, because the gene is acting at the cilia
At the
level.
photoreceptor, yeah.
So maybe.
I skipped that part.
Why
It was
should
little.
there be an RPE change?
Uh,
Not right?
Uh,
If the RPE is functioning well, why should there be fluid? If the
yes, ma'am.
RPE
No, no, ma'am.
hmm.
True, ma'am. Don't
And
know.
even in the patient scan, the RP looks okay. There's no disruption in the RP, which is there, definitely. That's why it's not clear what that cavitation is.
Hmm.
We'll have to learn more and read more about it. Probably it must
Yeah.
be somewhere. I've realized literature is full of things that we have in our minds. We just have to look for it.
Yeah.
So how is
Also,
the
like,
can I just ask, how is the progression of this condition? Because is it like,
It
or
is.
again, that is also variable, or how is it?
So, both this VMD version and the occult macular dystrophy, they progress very slowly over the years. Patients lowest vision recorded in some of the papers is 2200, 2400. It is not like they become totally blind. Some may become like legally blind, but it is not. Even patients who are ages 60, 70 years also, vision was. And then, as I mentioned, there is a lot of clinical heterogeneity depending on, with this gene. So, having the same mutation, but may have a lesser, severe phenotype, as some may have more. So if you can see the father's scan also, it looks very, the OCT looks very striking, but his vision is 636. The child's OCT looks so normal, but vision is 618.
Right.
So it is not really that way, although it is mentioned that, the area of that interdigitation zone loss and ISO's loss correlates with the vision. But there is a lot of clinical heterogeneity, but they are very slowly progressive disorders.
Okay. And you did a ERG also, right?
No, no. ERG is normal in them, fulfill ERG. So clinically also I was maybe MF ERG you can do, but I didn't do it. It was easier to diagnose based on the OCT and the genetic testing.
Right. Thanks. Good. Nice case.
Good evening.
Tanmay is asking why was there optic atrophy? Tanmay, you can speak up if you want.
Yeah, hi. So, what is the explanation for the temporal pallor and the cupping in that father, especially, and that subtle optic atrophy in the child also, which made you think of an optic
Yeah.
neuropathy in the first place?
So it
Is it
is
related?
probably the
reported in
secondary
those-
optic atrophy related to this. So the child's fundus actually, because he was referred like an optic atrophy, I was thinking in terms of mild temporal pallor, but I was not really convinced that there is a temporal pallor. The father still had some temporal pallor, but that's probably secondary optic atrophy to the little bit more advanced disease that he has.
Okay.
And cupping was there, but pressures were normal.
Normal.
Yeah,
So has
and
it been
visual
reported in any
visual
of
field
the
does not correlate with a glaucomatous visual field. So again, that I'm thinking probably either they have just genuinely large cups, both of them. I mean, like a family with having large cups, or It is like again a secondary cupping because of loss of RNFL due to the macular secondary optic atrophy, something like that.
Okay, so has it been reported in any of the papers that you read? Any optic nerve pathology along with the RP1L1?
No, no, it hasn't. But I'll check. I'll check. I was so focused into this VMD phenotype that I may have overlooked it, but I'll check.
Good evening.
Okay, thanks.
And
Yeah,
can I
if there are
talk?
no, yeah. Somebody's speaking?
Yeah. I am Dr. Lekha from Giridhara Institute, Cochin.
Yes, ma'am.
Yeah, thank you very much for this Zoom meeting. Both the cases were very interesting. Now, I want to share one of my patient. He's a 37-year-old and maybe a high myope with -8 in one eye and -7 in the other eye, 612 and 636 vision. He presented with a gradual decrease in vision for almost 15 years. And fundus examination had some kind of a bilateral atrophic lesion with some fibrous tissue also there. So first I thought whether it was a myopia related CNVM, but it was not looking like that. Then the next possibility was because of the atrophy, I thought maybe it is an atrophic BES with CNVM, and CNVM is known with BES. But EOG was almost normal. And for confirmation, I did a genetic testing. He had an RP1L1 mutation, which is likely pathogenic. But that time I was not aware of this pseudovitelliform associated with RP1L1. Only after listening to your case, I think maybe, but my patient had much more advanced damage than what you have shown with both the father and the son. So I'm wondering whether my case also fits into the same spectrum of disease.
Yeah, it is definitely fitting. As I mentioned, no, when I also looked at the RP1L1 gene manifestations per se, so these maculopathies which have been reported, they are ranging from very extensive Stargardt's, and I'll go back to that slide where they have mentioned, summarized. So severe macular degeneration, geographic atrophy has been described in two families, two patients. I don't know how many number of patients per family, but these are, and again the mutation is different from the common occult macular dystrophy, and then one rod cone dystrophy. Apart from that, one Stargardt's and RP. So these are all which can be associated with RP1. So maybe yours lies in that severe macular degeneration, geographic atrophy kind of a
Yes, probably. Only thing is, I had not come across this literature, so I learned everything from this meeting today. So I will read it up and try to correlate it better.
So I can share, if you write your email address in the chat box, I can share the literature that I searched.
Sure. I'll send it.
Papers, yeah.
Thank you. Yeah.
So thank you, everyone. If there are no more questions, then we'll call it a day. Thank you, everyone, thank you, ma'am. Thank you so much. So much learning from you always.
Bye.
Thank you, ma'am. Thank you, Dr. Shailaja. Bye, everyone. Thank you.
Yeah, bye-bye.